Welcome to Surgeon's Log 2020, Case Archives of the Skull Base and Beyond, a webinar presented by the North American Skull Base Society in association with Global Brain Surgery Initiative. I'm your host, Dr. Walter Jean of George Washington University. If you've enjoyed this and other episodes, don't forget to click the subscribe button on our YouTube channel so that you don't miss any future episodes. For now, put on your learning hats and enjoy this episode of Surgeon's Log 2020. Okay, our special guest today, the presenting surgeon, will be Edgar Ordonez Rubiano from the Fundación Universitaria de Ciencias de la Salud in Bogotá, Colombia. And we are really honored to have a senior discussant today, Dr. Edward Laws from Harvard. Of course, Dr. Laws needs no introduction. He is the past president of the WNS, the CNS, the FNS, the Pituitary Society, the WF. I said the WF. See, it's impossible to remember all your titles, Ed. And of course, he is a senior professor at Brigham at now and world-renowned pituitary surgeon. And on the hot seat today is Elizabeth Hogan from George Washington University, my own shop, who's a PGY6. So without further ado, we're going to start from one moment. The format today is a little bit different as opposed to the previous episodes where we have several surgeons from the same level to really debate the approach and whatnot. Today we have a more progressive sort of platform where I'm going to talk to a trainee, then we're going to have an early career surgeon talk, and then we have a mid-level seniority surgeon talk, and then we have, of course, the senior master talk. So it's going to be a somewhat more progressive platform than the other sessions we've had, so that'll be a little bit different. So without further ado, let's start with the trainee level with Elizabeth Hogan. The pool at Siloam. 50-year-old man comes in to see you, Elizabeth. He complained of 1 year of headaches and progressive peripheral vision loss with a 1 week history of pretty rapid decline of his vision. And he's referred by optometrists, ophthalmologists, and shows you this when he comes to your office. So bitemporal hemianopsia, let's not get into minutia here. And here is what you see. What are your thoughts with those views?
So you have a sagittal coronal post-contrast scans, and that looks like an axial, I think maybe a GRE. You see a large sella, suprasellar lesion that's expanding the sella, most likely compressing the optic chiasm. I can't really delineate it here in the imaging. It looks like almost a homogeneous, like cystic tumor with a little bit of enhancement, like more solid components in the posterior, superior aspect.
What do you think about the GRE? How about the history that could correspond?
I mean, so you would think with this sudden onset that this could be apoplexy, so that you would have sudden hemorrhage into the tumor, which could be why you have that, what looks to appear to be a large cystic component, but I don't really, is that black part, like I can't really tell there. I don't see any black on the, okay.
Right, the GRE is not clear, right? It's just got multiple signals, but it's not entirely clear that it is acute blood or not. Any thoughts about the lack of a headache complaint?
I mean, it is a little strange because normally from my very brief history of being in neurosurgery, generally patients with the apoplexy will have the sudden vision loss, but their main complaint is headache from the blood itself, I imagine. But it is kind of strange with this large tumor, especially compressing up, that they don't have any headache complaints.
Anything new here that you want to pay attention to?
Yeah, so you want to, with this view, you also want to look at your carotids because you want to have an idea of how they're situated. You want to know how far this extends up to kind of decide your approach to attack this. The carotids don't actually look like they're that close together. I still can't, it looks like that's the optic chiasm pushed up extremely superior, but it's hard to tell. But again, it's a very cystic lesion mostly.
What do you think about the laterality of the component that is to the patient's right?
I mean, it's slightly lateral. It's definitely superior to the carotid, but it's not extremely lateral.
Okay, so that's important, lateral. Right?
Yeah.
All right. So very quickly, what is this?
I mean, the
what's
highest
next?
differential is a pituitary adenoma with possible apoplexy. I mean, less likely a cranio, less likely a meningioma or sarcoid, other things that can present in this location.
What's next?
Patient is stable hemodynamically, so
Yes.
no Addison's or gross pituitary dysfunction.
Well, I don't
So
know
then,
about that.
okay, so then I would like pituitary labs, and we already have the official ophthalmological exam. So cortisol is low, testosterone, okay, so definitely has pituitary dysfunction, so you'll have to address the low cortisol before any kind of surgical intervention to avoid a crisis during surgery. How
What
is the
else?
sodium?
How's the sodium? Sodium is slightly hyponatremic.
Okay, and then you said prolactin's pending.
Yeah, you're gonna wait.
How long was the visual deterioration over?
7 days, according to the history.
Okay, so it was a slow decline of 7 days. Then,
Well, I don't know the patient, but I'm reading the slides. Edgar, can you help us with how long
was it like an immediate
how
decline?
rapid was the deterioration?
Yeah, so it was like 1 year before, and just subtle changes day by day. So it was only 1 week, right? For rapid,
Subtle changes. Okay.
yeah, small changes day by day.
How long does a prolactin take to come back?
That's a great question. I mean, each place is different, right? Even at GW, we send it out, don't we?
No.
We do it in-house now, but you know, a lot of places still send it out.
If you want to do the, if you need to dilute it more, that's a send out.
All right, but regardless, so the prolactin is cooking. You look at this and you say, well, what are the anatomical nuances, which you already touched upon a little bit? What are the anatomical nuances that you have to think about, and what are the therapeutic considerations here?
So for this, you have to think about how far superiorly it extends. If you think the tumor is going to be soft and kind of fall into your field versus hard and stuck and fibrous and something that won't kind of fall down. You also have to look at your carotids to see how close they are in proximity to each other, if it's even accessible endonasal, if it's something you'll have to do intracranial. You'll want to see how far laterally it extends, because if it's wrapping around the carotids or it's invasing the cavernous sinus, that might have more of an extension of your approach.
Excellent points. What about therapeutically? Do you need to do something? What are the possible goals?
So the main goal would be to relieve the pressure off the optic chiasm, given that this vision has been deteriorating, especially over 7 days. Given that you don't have complete DI, you'll want to try to maintain pituitary. You don't have complete hypopan, so you want to maintain pituitary function. So you also want to make sure that you keep the pituitary in continuity in the stalk. So those would be the two main goals.
All right, so there's a $10,000 question, a $100,000 question, and the $1 million question. The $10,000 question is, what is the goal of the treatment? What are you going to do something for this person or not?
Yes, I am going to do something for this person.
What's your goal?
My goal is to decompress the chiasm. Okay,
now let's say the prolactin is, you don't know when it's going to come back, and you don't know what the prolactin level is. Is the goal still to decompress the chiasm, what, surgically or what otherwise?
So that's a thin line, because if it is a prolactinoma, the argument is that even if you have visual changes, if you start them on Cabergoline, they get better. And everybody, usually the tumor decreases pretty quickly and they get better with time. So it's hard to say, but if the numbers come back inconclusive, then you would operate.
Oh, so you're going to wait? I just told you don't know how long it's going to take.
Yeah, I'm not going to wait. I'll do surgery also, given the cortisol level. So there is more going on. He's got low cortisol. So I think decompressing the area will do better for the patient.
So what's your first treatment before surgery then?
Steroids.
Okay.
Hydrocortisone.
All right. So, okay. $100,000 question. What is your approach?
I would do an endonasal approach.
So you want to go from below. Your goal is to decompress the chiasm. You think it's safe, even though it kind of wraps around that right carotid a little bit?
Yes, because I think that with this big cystic component, it looks like most likely if you get in there, that should all kind of fall down. And so,
all right, so decompress the chiasm, EEA. Okay, now here's the here's the $1 million question. Okay, so you're doing that, and you open, and then you open, and you get a gush. Okay, now.
Okay.
Not quite frank blood, not quite CSF. It's sort of just this ruby red sort of thing.
Yeah.
And then you open up a little bit more. And then you get like basically nothing. And then you're looking at above you this, your intracellular looking high, okay? You see all that.
Yeah.
Now, and nothing's coming down at you, okay. You have no idea how much shift that has occurred with that fluid coming out.
Yeah.
You're looking at that. What's your next move, if any?
And you're saying that when you try to release it, nothing's coming down. So when you do very gentle curetting or suctioning, nothing's coming with it.
No. What other maneuvers can you do to encourage something to maybe come down?
You mean like doing some Valsalva to try to push the diaphragm to get some to come down?
Okay, that might be one move. What any other moves?
That's the one that's coming to my mind right now.
Okay. Did you put a lumbar drain in this patient?
I did not put a lumbar drain in this patient.
Would you?
I would not have, no.
Would not have. Okay. So what do you do now? You gonna go after this?
Well, I would put the scope back in and take a look and see what my visualization is. If I feel that I have good visualization, then I would try to go after it gently. But if I feel that it's pulling too much with knowing how it wraps around the carotid, I probably would abort and then just get imaging to see where they are and plan for another approach if needed. Because I still don't know the prolactin level as well. So if it was a prolactinoma, I could hurt this patient when.
All right, fantastic. Dr. Ordonez, do you have any questions for our trainee?
Sure. I don't know if you can go a little bit back on the video. So
I don't think I can. I might not be able to. Okay, well, there you go.
Okay, a little bit go ahead a little bit more. Sorry. A little bit. So there you go. Can you stop it there?
Stop it there if I can.
Yeah. So there you can see that there is something on the left side and something on the right side inside the resection cavity, right? Mm-hmm. So what those things do you think they are?
I mean, it could be the optic. I can't really see that well. I mean, it could be part of the optic chiasm coming in and out. It could be, if it's on both sides, I mean, that's what I would think, because it looks kind of white, but it's really unclear.
This? Yeah, Edgar, I'm not sure that she can see exactly what you're talking about.
Yeah. That one that you were pointing.
Okay.
Yeah. Sorry. Yeah,
so it looks like nerve, most likely from this blurry picture. So I would imagine part of the optic chiasm, but then that would mean you went through the diaphragm sella. So I don't know from this picture.
Yeah, it's kind of tricky. Sorry.
All right. So Edgar, what did you think it was when you were in there?
Yeah. So at this point of surgery, I was pretty sure. Sorry that it's not the best quality video, but it was probably the diaphragm sella. Right.
So you thought it was part of the diaphragm center. Okay, yeah. So anyway, Elizabeth, thank you. I think that was excellent discussion of some of the nuances. We are now going to turn over to Dr. Ordonez, who is from Bogota, and he's a very early career, very young neurosurgeon, but very well trained and with tackling some very complex disease in his country. And he's going to show us what he did with this very challenging case. Edgar, to you.
Okay, thank you. Thank you very much. Thank you for your invitation, Dr. Jim. Thank you for all panelists for your time here. Okay, can go ahead. Thank you. So we definitely decided to go for an endonasal endoscopic approach, right? Because we thought we were going pretty straightforward to the cystic component that probably we were able to drain, right? And hopefully to get down the most superior aspect of the tumor. Obviously trying to avoid neurovascular manipulation and brain retraction as well, even that the tumor was going laterally over the right ICA. So now I would like to consider this because unfortunately in Colombia, we don't have sometimes, the possibility to do preoperative screening for COVID. So probably this would be also an option now, a transcranial, probably a RATIONALE approach to get the solid component of the tumor and drain also the cystic component of the most inferior aspect of the tumor. So this is an illustration just to show that this tumor was going also a little bit into the right cavernous sinus. And well, I brought this case because it was one of the first cases I did when I graduated from a residency. And as you said, I was not sure where was the optic apparatus in the preoperative MRI. So my first goal here was also to drain this cyst, right? As unfortunately we have to wait for the PROLACTIN in our institution because we have to send the samples to another lab to process them, and then sometimes it's like 5 days, sometimes it's a week, sometimes we don't know exactly when it's going back. So it's hard to say where or when to stop if it's a prolactinoma, right? In the right side, we have just to discuss a little bit this because so we first decided to harvest an nasal flap because we thought that probably if we decompress that tumor, we were not sure if we were going to go extracapsular or only intracapsular for the resection. So we went up into the top of the cella, and we were also, prepared if we needed an endonasal extended approach here, going also into the tuberculum, and our lateral limits were above the optical carotid recesses. So this was a very interesting case because he was a cousin of an anesthesiologist of our institution, and he didn't have a good health insurance cover company. So we went for donations here, and as rapid as possible. And we don't have a neuro-navigation system in our institution, so we have to rent it. It's like $800 per each case. So we found this neuro-navigation system on all the things from the hospital to cover the surgery and the ICU postoperative care. So we knew that we had to decompress the optic apparatus, right? Trying to recover some visual function and avoid more deterioration in this patient. Sorry that I didn't put in the clinical history, but this guy was also with acromegaly. So we were not sure if it was combined acromegaly and also prolactinoma.
Well, what was the IGF-1?
Yeah, sorry. Those were normal.
Those are normal?
Yeah, the IGF-1 and the GH were normal for this patient. So for these endonasal cases, we use the forehand technique with the ENT guys, and we use always the neuro-navigation system, and for extended approaches, we use, sorry, this was not for the patient, we also try to use the graft. Okay, so we have.
So here's your full video.
Okay. So we harvest the nasoseptal flap, try to do a wide sphenoidotomy with the carousons going as lateral as possible. We use a little knife to open the dura. And then we try to drain this slowly to avoid DI, right? To if the tumor was going down. This is something that I talked to Dr. Preoperatively, that he used something to put the tumor up during the decompression to avoid DI. So we open a little bit more here, and we use the micro scissors to open in a cruciate fashion, and the ring curettes, trying to get a part of this solid components of a tumor. Then we use a suction to go posteriorly and as lateral as I could at this moment. Here in the left, I thought this was the pituitary gland, and it was confusing for me. I couldn't get this with the suction at this try, neither with the ring curettes. So I preferred to stop there, as I didn't know if it was a prolactinoma, and maybe this was enough to do the recompression. I put some gel foam and Surgiflow to avoid postoperative bleeding, and then put back the nasoseptal flap. So unfortunately, this was the 1 month post-op MRI images, and the tumor came down just a little bit. There was yet a solid and cystic component of a tumor just going laterally to the ICA, the right ICA.
And you can see the chiasm now a little bit better.
Yeah, a little bit. So the patient recovered clinically like 50% of his visual function that was deteriorated before surgery, and the prolactin came like 400, and obviously at this point we knew that it was a prolactinoma, and the patient had transitory hyponatremia for the first 3 days post-op, but he didn't need DDABP afterwards.
So at that point, you started giving him Cabergoline, right? That's how the progressive decrease.
Yeah, with the endocrine guys. So he was at this point with replacement with levothyroxine and also with prednisone, and he started on Cabergoline. This is a 8 months post-op enhanced MRI showing a little decrease in the volume of the tumor. Now you can see that the anterior communicating complex is now a little bit decompressed. The cystic component of the tumor decreased also in volume. And unfortunately, he had a new visual decline after treatment with Cabergoline, because we have a real great problem with some health insurance companies, that they don't cover always the Cabergoline, and the treatment is not as we would like to, and it's so expensive also for our patients. So that's the main.
But Edgar, let's clarify this. The new visual decline is because the Cabergoline got cut off, or was a new visual decline on Cabergoline?
So he just had like 3 or 4 months with Cabergoline, and he stopped. So after he stopped, like 1 month after he stopped, started again slowly.
So this was not a failure of Cabergoline. This was a failure of the healthcare system.
Yeah, absolutely. So we decided again to go for a reoperation because there was probably not good, a follow-up with the endocrine guys and to do a good treatment with Cabergoline. So we went again for an Endonasal endoscopic approach. Probably this time also we needed to do a decompression of the optic apparatus, but we were going definitely for a posterior resection, aiming to do visual recovery.
So you did a redo here, same positioning, same sort of setup, and then here's your second video.
Yeah, so we put down the nasoseptal flap, and we open a little bit more of the sphenoid sphenoid bone here, opening to put the 45 and 30 degree scopes. We open here again the dura and the tumor capsule, and use the micropituitary rongeurs and some curved dissectors to get this fibrous components of the tumor and ring curettes, and this is with the 30 degree scope. And here you can see the diaphragm cell coming down, these fibrous parts of the tumor avoiding to come down the diaphragm cell and the posterior aspect of the tumor. Now we go laterally with the 45 degree scope to get into the right cavernous sinus and to get in decompressed. Then we put again this gel foam and put back the nasoseptal flap. So this is a immediate post-op MRI of this patient. Now we thankfully got a restorative resection with decompression of the optic apparatus, preserving the, in that right part, the pituitary gland as well as the pituitary stalks. So this patient didn't need any further treatment. And this is the consequent MRI of this patient.
So Edgar, did you put him back on Cabergoline? Was that possible after the second operation?
So the endocrine guys didn't want to continue as the levels of the PROLACTIN also came down after this second surgery. So they stopped by this moment, but he has a new insurance company. So probably if we need to start again on Cabergoline, probably he will have a better treatment now.
Okay. So thank you for that case, Edgar. I mean, it was, it's a very interesting case and brings up a lot of issues to talk about and a lot of things to discuss. When I told you at the beginning that this is going to be a trainee to early career to mid-career surgeon to senior surgeon, you probably thought that the mid-career surgeon is going to be me. But I'm actually going to turn over the podium to Dr. Ed Vates, who incidentally was my roommate from medical school. So he and I are the same age. But I can tell you that he does a lot more pituitary surgery than I do, and he's far more qualified than me to be the mid-level, mid-career surgeon to discuss this. So Ed, two Eds here, and Edgar too.
Ed the lesser and Ed the greater.
Ed the lesser and Ed the greater.
I resent
that. We're like nested dolls, nested Russian dolls. I'm somewhere between the little one and the big one.
So the mid-career Ed, shall we say, what your reactions to what went on and your points made and so on?
So first of all, a fantastic case, and I think it encapsulates a lot of what can sometimes be very nuanced decision making in pituitary tumor surgery. I mean, cystic tumors like this are not uncommon, and so then you have to think carefully about what the goals of surgery are, and then also think that sometimes your goals of surgery are achieved in a staged fashion. I think that regardless of what you may or may not have wanted to achieve in terms of gross total resection, decompressing the cyst achieves a lot of what is most important to the patient, which is recovery of vision and decompressing the.
Oh, you just went mute. You just went mute.
Related to socioeconomic factors and not medical decision making. But usually when I'm doing these cases, I like to get a maxillofacial CT scan. Because oftentimes the anatomy of the sphenoid airspace itself tells you something about how easy or how hard it's going to be to have both your endoscope and your instruments in there, and it also gives you a sense of some of the bony landmarks, which
some of your decision making based on that. The other thing that struck out to me was how much it extended up into the third ventricle, and that can sometimes mean that what you're seeing above the sella, the suprasellar component, will not necessarily drop down as easily as you might think it would. When the tumor is adherent to the inferior aspect of the optic chiasm, that's one thing. But once it's really embedded itself up into the third ventricle, oftentimes tumors are not as likely to drop down. Now, that doesn't mean I wouldn't have still approached it endonasally. I would have. But I definitely would have considered having a lumbar drain in with that surgery, no question. Partly because you can inject through a lumbar drain to get things delivered down into your field. Also because you can inject fluorescein and use that to know once you've reached the dark side of the moon.
Would you have gone deeper? Would you have gone more, or would you have stopped at the
Yes, I would have. I mean, at the time that, well, I would have thought about stopping, but I probably would have gone further. And part of what I was going to point out just on the initial video, not the second video, which resulted in the much bigger resection, the bony opening went up to, but did not extend past the tuberculum. And at least based on what I could see. And I definitely think I would have opened up more bone above, because if things weren't dropping down during the initial surgery, that's when I would have divided the dura further, identified tumor capsule, and then done an extracapsular dissection at the time of the initial surgery. And again, that's where having a lumbar drain and fluorescein is helpful. And then just a couple of other points that I would make based on what I saw. First of all, it's interesting that the prolactin was only 400. You know, for a lot of pituitary tumors, the size of the tumor doesn't always correlate with the degree of hormonal dysfunction or hormonal abnormality, but for prolactin, it usually does. Now, maybe the fact that this was mostly cystic changes that, but even for the solid component that you could see, I'm still surprised that the prolactin was only 400. I would have expected something over 1,000. Now, that doesn't mean
well,
let
me ask you this question. Let's say that same scenario, Ed. If the prolactin was a little bit higher and you had the prolactin pre-surgery, which is what we're used to in our country, when is it wrong to operate? When is it right to operate on the prolactinoma?
Well, I can tell you in our institution, you know, I will frequently tell patients I'm just a dumb brain surgeon and the endocrinologist will make the decision on this. Fortunately, you know, I've also come to realize over time, my endocrinologists have become the most aggressive pituitary surgeons I know. You know, I think this is a situation where, at least in our institution, the fact that it was mostly cystic, even with a prolactin level, let's say the prolactin level was 1,000, in this particular setting with the acute vision decline, our endocrinologist would have been telling me to go ahead and operate, because they know that I can drain the cyst at the very least, may be able to decrease the tumor bulk. That'll make Cabergoline much more effective. And it's also the most immediate way to relieve compression of the normal pituitary gland and the optic chiasm. So I think that this is a situation where in a prolactinoma, they would have argued for surgery. Now, the other things I was going to say, just in reference, unless you wanted to follow up on that question.
No, go ahead.
First of all, I'd never get an MRI scan at 1 month. And the reason I say that is you're never going to see anything good there. You're only going to see badness. You know, the reality is once you checked your MRI scan, I believe it was at 8 months, there had been significant drop down of the residual tumor. And, you know, this has not just been described for pituitaries, it's been described for acoustic. Bob Ogerman actually talked about doing subtotal resections of acoustics to allow the part that's embedded in the brainstem to deliver itself out with progressive pulsations of the central nervous system. I think that if I had gotten to where you were, where the cyst was drained, nothing was coming down, I would have elected to potentially stop and then follow the patient symptomatically, follow their visual exam, recognize that they could be treated with Cabergoline, put them on Cabergoline, and then check an MRI scan at 3 months or 6 months, and then think about what needed to be done then. And if they were continuing to improve on just the Cabergoline and were able to maintain that as a treatment and not running into the kind of difficulties that your patient did, I might very well have just waited longer before deciding to pull the ripcord for another surgery. Now, the last thing I wanted to point out was, and this relates to the coronal anatomy with that portion of the tumor that was projecting over the patient's right internal carotid artery and potentially involving the right cavernous sinus. Looking at your post-op MRI scan, I don't think that what you've got residual over the right internal carotid artery is actually the patient's pituitary gland. I think you may still have some residual tumor there, and that's not a big deal. I wouldn't change anything as a result of that. But the point I'm trying to make for Elizabeth and for the trainees that may be watching is that the normal pituitary gland will typically be deviated one side or another. And the side to which it is deviated, you're less likely to have cavernous sinus invasion because the pituitary gland may actually shield that cavernous sinus from the tumor expansion. And so my suspicion is actually your normal pituitary gland may have been over on the left side.
Other side,
That's
yes.
why you had more extension over on the right side. And like I said, if that is the normal pituitary gland over there, then yeah, it's over on the right side. And if it's not, and that's residual tumor, so what? You know, if the patient can stay on Cabergoline or is not having elevated prolactin levels, I would just leave that alone.
Oh, excellent points, and that's why I defer to you, who do a lot more pituitary surgeries than I do. Excellent points that you've made. This case brings up a lot of global neurosurgery issues as well. You know, the availability of Cabergoline, the follow-ups with endocrinologists. The issue, Edgar, is that I think there is still tumor left, and if this guy doesn't go on Cabergoline for the long term, that may recur. I'm going to go a different direction totally from Professor Vates' comments and go the complication avoidance route. I saw something on your second video that scares the bejesus out of me, which is the rongeurs inside the cellar. And this is just coming from someone who's done the bad things before. I always tell my trainees that the curettes can go in the cellar, but intracellar or beyond, no grabbing instruments go in. I personally, you know, grab some wrong things, and I've seen trainees grab some wrong things too that leads to catastrophic outcome. So I think that you got to be somewhat careful with the grabbers intracellar and beyond. I don't know what your thoughts on that is, Ed.
Okay, so I'll start as Edward the Lesser. I think that that depends on your comfort level, and it depends on your sense of feel and really what you do. I do routinely take the curettes out past the field of view. I try to minimize it, but you know,
the curettes, yes, not the grabbers.
Correct. Well, no, I would never actually use a pituitary rongeur out past where I can see it. But the curettes frequently, you know, especially for a tumor like the one you were attempting, what I would have done is initially focus on all of the tumor that was at the floor of the sella, and then working my way back until I could identify the dura along the clivus. And then once you identify the dura along the clivus, you can typically pick up where the capsule of the tumor is there. Then you kind of sweep out to the right and sweep out to the left within the cellar component and try and capture or remove all of the tumor that is within the cella itself. Because once you have done that, that's when the supracellular component starts to drop down. If you still have tumor, especially up against the cavernous sinus on one side or the other, that's going to act like a tent post. That's going to keep the supracellular component from dropping down. And that's why I really always focus on sticking midline initially, focusing on the inferior aspect of the tumor, and then following the curvature until I can identify the dura along the posterior clivus. That's also one of the reasons why I mentioned getting a CT scan, because you know, sometimes the bone can be completely eroded along the clivus, and then you're into a whole different world of hurt if you just go stabbing back there blindly and suddenly discover you're looking at the basilar artery of the brainstem. But that is usually how I would approach some of the dissection of this.
Okay, so now we're going to turn the podium over to the master. And Professor Laws, I would invite you to share your screen and then go to a slideshow and enlighten us how we can do better.
Okay, I need to find the share screen piece down here.
It's the green button at the bottom of your Zoom
Yeah,
window.
but I'm not seeing it. I don't know why.
Your Zoom window should have a green button at the bottom.
Yeah, well, it should, and I don't see the green button at the bottom. I have my trusty here. There it is. Got it. Okay. That's not what I want.
There's what you want.
Is it you had it? You have it?
We see your screen, but you can go to the slide mode.
Yeah. I have to just do the slideshow. Yeah. Okay. There we
Perfect.
go. I hope that Walter will enjoy the color scheme.
I noticed that right off the bat.
You did. I thought so. Okay. I'm starting with some important things. Number one, the endocrinologist has to be your friend and not the enemy. And so it's very important to cultivate an endocrinologist and their help. And this is just me a long time ago with Georgie Murasan. You may remember him. He played for the Washington team. And and Mary Lee Vance, who is my colleague in endocrinology for 15 years. And as a result, I never hesitated to recommend dopamine agonists for prolactin secreting tumors. And if you do in your regular practice, not these urgent ones, but in your regular practice of seeing a prolactinoma, always give them an option for medical therapy. And if they don't respond, they'll come back to you because they know you and they trust you, and they'll think you're a hero. If they respond, it's almost as good. So think about that. Now let's think about apoplexy. It's very hard to define. Some people define it one way and another. It's really a clinical diagnosis, and the problem is that it imitates so many different things for the people in the emergency room who tend to see these patients. And they can be, I've seen all of these diagnoses mistaken. And some of the patients died or went blind because they were diagnosed as a stroke or a subarachnoid hemorrhage or meningitis or some kind of seizure or some kind of migraine with ocular migraine, or functional disorders, or people who were even pretending that they couldn't see. I had a couple of inmates from prison who pretended they couldn't see and thought they had won the game by proving they had a pituitary tumor. It wasn't true. Now, patients with true pituitary apoplexy, you've got to remember and teach your colleagues the thing they need most of all is emergent steroids. Dr. Ordonez's patient had extremely low cortisol, and the patient can die of adrenal insufficiency under the stress of being cared for if you don't replete the cortisol immediately. I usually use Decadron because we trust it so much in neurosurgery, but you can use anything as long as it's given in high doses. And furthermore, if the optic chiasm is being compressed, it tends to protect the optic pathways, just like it protects brain when we treat other kinds of brain tumors. Now, this patient, obviously, I would not do from below. The sella is not enlarged, and this took a craniotomy to get this apoplectic tumor out of the patient's head. So replete the insufficiencies. If they are low in thyroid, don't only replace the thyroid, because that ramps up their metabolism and makes a greater demand for cortisol. And if they're already hypocortisol, they can again go into an Addisonian crisis. So down here it says, do it slowly and carefully, lest you precipitate an Addisonian crisis. I always check calcium too, because some of these patients have other hormonal issues. Now, the positioning is, for me, I'm a fanatic about the positioning. This is the positioning I've used ever since 1967. You see the C-arm in place. Many of our neurosurgeons have been led astray by their ENT colleagues who do all the patients flat on the table with the table horizontal. And there you take no advantage of the physiology of the patient in terms of the brain and the pulmonary system, and whether or not there's going to be pressure to push down a tumor that's extending into the suprasellar spaces. Now, the first thing to notice is the head. I position the head in the middle of the room so that the midline of the patient is parallel to the walls of the room and the midline of ambient space. I cock the head, left ear down to the left shoulder so I can stand here without killing my back, which I have done. I have had several back operations and may have another soon. At any rate, here's the position where the patient is in a beach chair position. The table is flexed at the hips, so the thorax is elevated to 25, 30 degrees. The head is tilted, as you can see. We often tilt the entire table just a little bit to be a little more comfortable. And the assistant stands here on my left or around the top of the head at the table now that we don't have all this stuff in the way, and we're doing I use three-handed endoscopy and have ever since the beginning. But I think the table is key and it should be taken advantage of. After all, they cost more than a Mercedes-Benz, and we never take advantage of them when we use them completely flat. They're very versatile and can help you with your ergonomics and can help the patient with his or her physiology. Here's the position that we use, a very competent assistant who can handle the long scopes when we go intracranial. And this resident is working with two hands, two-handed microsurgery. My first visit to Pittsburgh and in 2000 was completely dominated by the ENT work at Pittsburgh, and Danny was there at the time as well. And all I saw was the ENT surgeons pushing and pushing and pushing, using no sharp dissection, using two suckers to move things around. Really crude when you compare it to what we neurosurgeons all know as two-handed microdissection. And I didn't see that as much in the examples that were given as I usually do. Now, with regard to forcing the suprasellar down, I don't use LP anymore because I learned from Ivan Chirek. I don't know if any of you had the joy of knowing or working with Ivan Chirek, one of the real pioneers of transphenodal surgery, but I was at Northwestern with him watching a very difficult case, and he sent the resident down underneath the table to put the resident's hands on the patient's neck under the drapes and squeeze on the jugular veins. And that is really wonderful. It works just as well or better than air or saline injection through a lumbar puncture. All you have to do is compress the jugulars, the CSF pressure goes up and the tumor comes down. So don't forget that. You can save a lot of trouble by doing it. Now, what about the posterior pituitary? I think it is important to avoid damage to the posterior pituitary and the stalk, because you certainly don't want to give a patient diabetes insipidus. And that was one of the goals of the operation that Dr. Ordonez did, and he was successful. However, let me tell you, when the sella is enlarged by a microadenoma of any kind, that pressure produces an atrophy of the posterior pituitary. It basically disappears. And if you carefully study your sagittal MRIs, you will not see the bright spot of the posterior pituitary on a patient with a macro. What happens? The endings in the posterior pituitary are compressed and they atrophy. If you don't damage the stalk, the cell bodies in the hypothalamus will not die of karyarexis. If the axons are not injured, they will survive and they will continue to get the ADH into the system. And if you have to do anything with the posterior pituitary, do it with very careful, sharp dissection so you don't pull on it and tug on it and damage these axons that produce a retrograde poison for their cell bodies. And this has held true for me for a long time. And our incidence of permanent DI is very low as a result. Now I want to show you just an example of an extracapsular removal showing how the two-handed microdissection, this is obviously a non-functioning pituitary macroadenoma, but you're going to see the normal gland here. And look at the interface between the normal gland and the pituitary. If you can see it with the endoscope, and that's why we use the endoscope, you can see that cleft, and you can use two instruments, and you can use microsurgery and all your skills, and you can take that thing out with extracapsular, intact, preserving the normal gland. I recommend it highly. Finally, this is skull-base surgery, and this is one of the most elegant parts of skull-base surgery. So I always go over the principles, the basic principles of skull-base surgery whenever I talk about these endoscopic cases. First of all, we all do this. We understand and visualize the anatomy and the pathology. If you get too much bleeding and you can't visualize it, you're not doing the right job. And I'm constantly telling my students, suck the blood, suck the blood. This is visualization with the endoscope. You have to keep it clear. We remove the obstructing bone. And as Dr. Vates said, I would have done a bigger bony exposure in the case with tumor that big, because I think you have to go to the very biggest margins so you get the best angles on the tumor and the normal gland. We always avoid brain retraction. We are able to preserve and reconstruct and bypass major blood vessels. We preserve the cranial nerves. This one, I think, and the one I'm going to show you, had an injury because of the surgery, which wasn't preserved. And we reconstruct for protection and cosmesis. And I reconstruct the sella in almost every case. I do use a nasal flap when I'm expecting a major CSF leak. But we always use and we always teach microsurgery and microtechnique. And we most of the time work collaboratively with our colleagues in ENT and other forms of skull-based surgery. And it's a joy to do that, to teach each other, to work with each other, and to give the patient the best possible. Now I'm going back to this concept of the endocrinologist being your friend and trying to convince them that there is a rationale for surgery first in PROLACTIN microadenomas. This is a little off the apoplexy subject, but I want you all to know this, and we're going to try to present it at the skull-based meeting. So when do we think that surgery is the best first choice? In tumors that are not responsive to medical therapy, or there's no lowering of the prolactin and no shrinking of the tumor despite the medicines that are being given. Now, for the side effects of cabergoline, we reviewed a recent series of 33 women with microadenomas. 24 of those 33 women came to us for first-time surgery because the side effects were so bad, and these have not been recognized or talked about by most of the endocrinologists because they just love to give medicine. Patients have an uncertain length of time that they're going to have to take persistent medical therapy if that's all you'll give them. And we have excellent results with endoscopic surgery, and we had a 94% initial normalization of these 33 patients with microadenomas. And here, finally, are the side effects in 24 of those 33 patients. Headache, not so special. Nausea and vomiting, pretty common. Fatigue, depression, dizziness, anxiety, panic attacks, insomnia, presyncopal state and hypotension, suicidal ideation, inability to concentrate, weight loss, hypertension, palpitation. These occurred, and maybe they weren't all the results of cabergoline, but the patients were convinced they were, convinced that they were, and so we were happy to operate on them. And as I said, most of the time we had very satisfactory results. So those are my comments, and they were all stimulated pretty much by these wonderful presentations. And I'd love to get rid of my screen sharing. Stop the share. There, we're back. Okay, a couple of other comments. Cystic tumors we thought were indications for surgery all the time. It turns out there are some reasonably good papers that show that some of the cysts respond to cabergoline. They don't all respond, and if the patient is symptomatic enough, I still believe that if they have a large cyst like the one that you had, you need to operate on it. I told you everything I really know about diabetes insipidus, but not about SIADH. It was the most common reason for readmission to the hospital for our patients with transfemoral surgery. And the reason why was because they were receiving too much fluid, and we'd send them home in a day or two, and they, you know, a lot of the women will drink quarts and quarts of water every day because they think it's healthy. And we had about, I don't know, 17% SIADH hyponatremia problem. Now we send them home with a 1 liter pitcher, and we tell them their fluid intake is reduced to 1 liter a day and for a week when we check their sodium. And since we've done that, we've had 0 hyponatremia. So I think that's important. So those are just a few things that I hope will help neurosurgeons of every category
So,
when
so
they're
Ed,
dealing with these problems.
thank you for that, Professor Laws. Brilliant as always. I'm going to give you your version of the $10,000 and $100,000 questions. The $10,000 question. You said that this is a cystic tumor and drainage cyst and so on and so forth. Did this case fit the criteria for apoplexy? Was this apoplexy? Is apoplexy a radiographic or is it a clinical diagnosis?
No, I believe, as I said, it's a clinical diagnosis. However, the only thing he didn't have was headache, right?
Right.
He had adrenal crisis and the symptoms thereof. He had profound fatigue.
Right.
He had, I don't know what his blood pressure was, but I bet it was low. And he had progressive short-term visual loss.
Okay.
Now, I think you have to assume that he had some enlargement of the pre-existing cystic lesion.
Yep.
And the most likely thing was bleeding, but we don't know that for sure. But it looked like when you opened the dura, it sure looked like it had blood in there. It was like motor oil, red motor oil. So, but he must have had the tumor for a long time because of how thick the dura was.
Okay.
So that thickening of the dura is, evidence that he's had it for some time with the irritation that goes along with the thickening of the dura.
So the second question
But also, you could have used if with a bigger exposure, you could have used an angled endoscope and maybe have seen a plane between the necrotic pituitary tumor and the residual normal gland.
Second question to you, that if you had faced the same, so the cyst got drained out and you have this unknown thing up there, but when he stopped, would you have gone further?
What?
Would you have gone further?
Oh, yeah.
You would have gone further.
Yeah, I would have with two instruments, with microdissection. And like Ed Vates said, I wouldn't use the grabber. I'd want the diaphragm to come down. But sometimes if you look particularly off to the side, you can find a plane. Sometimes, as he noted, if you get the posterior part mobilized, you can flick it up and have a good plane that will ultimately let you save the normal gland.
At Vates, Dr. Vates, you have something to say?
Yeah, what I was going to say about the pituitary apoplexy, I think that in my practice, I've seen a lot of what I've come to term formed fruits of pituitary apoplexy, meaning a patient will have sudden onset of headaches, they'll be seen by their primary care doctor, they'll be treated for migraine, they'll keep puttering along with their headaches start to get a little bit better, finally somebody thinks to get a CAT scan, and lo and behold, there's a big cellular tumor there. And then they end up walking into my office as opposed to showing up in the emergency room. Even occasionally I've had patients who present with sudden onset third nerve palsy and headaches diagnosed by their ophthalmologist as having diabetic third nerve palsy. But then they will come in because someone will have still gotten an MRI scan of some sort and lo and behold, there's a pituitary tumor. So normally we think of pituitary apoplexy as being a cataclysmic event. And I do think that it's a clinical diagnosis, not a radiographic diagnosis. I've had plenty of patients sent by catapult to my office because the radiologist read, pituitary apoplexy, blood inside of a cellular tumor, and they're walking in, they have no headache, they feel perfectly fine. It's a clinical diagnosis, and typically it's that cataclysmic onset of headache, vision changes, alterations in mentation that reflect profound, sudden panhypopituitarism and compression of the optic chiasm and adjacent dural structures. But you can have this formed fruits that is more like a slow burn as opposed to a sudden explosion.
Right.
This case also brings up a lot of interesting things on the global.
I have another case, that it's pituitary apoplexy that's pretty cool, and
go ahead.
Point. If you
go
want
ahead.
to see it, if I can get it on. Where is my? I hope this is it. Wrong one. Sorry. I have to get rid of that and get this one. Got it. Oop, what happened? I messed it up. Yeah, here we go. Can you see this one?
Excellent. Let's go for it.
Okay. All right. Here's a neat case. A 51-year-old woman who woke up with the sudden onset of headache and double vision, and we'll call that pituitary apoplexy clinically, right? And she was presented, living in Bermuda, and sometimes we get, I wish we could go to Bermuda to take care of them, but sometimes the patients come here, and you'll see the scan revealed a macroadenoma, and they gave her some hydrocortisone at our request, and then flew her over here. And she had a little evidence of pituitary involvement. She was taking these medications. Her exam was pretty good. She did have normal pupils, but she had a left sixth nerve that produced the diplopia that she was complaining of, and she had a little superior temporal field cut, but normal visual, pretty normal visual acuity. Diplopia on left lateral gaze, no trigeminal symptoms or anything else. Her exam was otherwise normal, really nice lady. And here's what she came with. This is the CT scan from Bermuda, and we sure thought this was an episode or a scan relating to pituitary apoplexy. This was a CT scan we used for navigation because we took her fairly promptly, it was on a weekend, to the operating room. And she was in good clinical shape except for the visual loss and her headache, which had relieved somewhat. And here's the another thing, looking at this blood clot in there. And we were all the more convinced that she had pituitary apoplexy. Here's the sagittal view. What do you think? Do we take this right to surgery?
That looked like a CTA. Did she have a left internal carotid artery?
Yeah.
Yes, she had a left internal carotid artery. Yeah, here's what the CT, the MRI that we saw.
Let's go with Elizabeth. What would you do?
I mean,
What's your next move?
I'd like to see the rest of the MRI. So it looks like we have a large tumor within the sella. The carotids do look like they're very tiny, but they're there. I would take them to surgery.
Edgar, any thoughts?
Who, me?
No, Edgar.
Well,
Edgar.
I think it's well for surgery. I don't know. I have had 2 cases similar to this one, and I have a good experience with with the clot and everything. With time, with the Cabergoline, like 6 months. I don't know exactly if this was also the case for it.
Well, actually, her PROLACTIN came back before we actually took her to the operating room, and it was normal.
I would not do anything until I have a vascular imaging study, because I'm smelling something odd here.
Yeah, I want an angiogram.
You're a wiser man than me. Here's what the imaging people said. Sound right?
Yeah, I still want to see some vascular imaging.
Okay. There's the labs. Okay, given pituitary apoplexy, requires admission, blah, blah, blah. Okay, intra-op, here we go. I fractured open the widely exposed the dura. The dura was abnormal. It was blue, distended, white tissue up above the bottom part, which I thought was the normal pituitary gland, just above the clivus, above the blue spot. However, I was walking into the room just as my fellow was taking an 11 blade to open the dura.
Oh God.
and I was looking hard at the dura, and I said, Zach, get the Doppler and check it.
Oh God, it was Zach.
Right. It was Zach. And he put the Doppler on it, and you can't believe I wish I had the recording. It sounded terrible. You could hear the whoosh, whoosh, whoosh of the small connection between the carotid and that big aneurysm, right? And we reevaluated things. And so we had an angiogram. And what I did was I put some gel foam across the dura, which was exposed, and then I reconstructed the cellar floor so as to contain it. And here's the angiogram. How's that leg? That's pituitary apoplexy for you.
Well, I haven't seen this case before, but I have seen this case in real life before. Yeah. So I'm just, really skittish. I'm still
no, you're very smart.
PTSD
I wish I'd been that
one.
smart. And the radiologist later said, of course, they knew that's what it was, but they didn't show us the films that showed it. So there you go. So we did BTO and a SPECT scan, and here's the coiling. Can you see the coils?
Yes.
Yeah. They did a beautiful job coiling it. Here they are.
You shine a bright light up her nose. Can you see the reflection off of the back?
Right. So she survived with just a permanent left 6 nerve palsy. But we all learned a lot from that one. And I never do a case without the Doppler. And I use it just as much as I do the endoscope. So,
wow.
So that's what you can do.
Well, thank you for sharing that one. Yeah, don't fall into that trap. I have. So you only had to fool me once, right? Kind of thing. The case that Dr. Ordonez brought actually brings up a lot of interesting issues on the global scale. And, Ed is, of course, the past president of WFNS as well. We have Claire Karakisi on the line here from Rwanda.
Hi.
And, it's very interesting that and Professor Laws, you said that, collaborate with the endocrinologist and that's very important. But in a lot of places, that's just plainly not possible. So Claire, can you enlighten us as to what it's like in Rwanda with, you said you don't have an endocrinologist, there's not enough people, or what is the situation there? Claire, can you unmute yourself?
Hi.
Hi.
Hi, John. Hello?
Yeah, go ahead. We can hear you.
We got you.
Can you hear me?
Yeah, we do.
Hello?
Yes, Claire, can you hear us?
Yes, I can hear you. Thank you. Thank you for, letting me participate at this session. So we had one endocrinologist, but who has been busy in the other hospital. So current patient I have, I see a lot of PROLACTINomas. I try to do what I can, and from what I learned, from what I learned from my fellowship with Dr. Gentili. When I can manage Cabergoline, I start slowly, then I follow PROLACTIN levels, and hopefully, they come down. So this a patient I've been seeing recently. She was operated in India, but prior the operation, she was diagnosed to have a PROLACTINoma with high levels of PROLACTIN over 2,000. So she was operated, PROLACTIN levels came down, and she was put on Cabergoline ever since. When I saw her, she's still on 2 milligrams of Cabergoline per week. And she still has PROLACTIN levels around 200. And she's 27, married, and no kid yet. So I was, I've been facing all these challenges. I've been looking in the literature and see, I requested a new MRI. She just has a small residual near the cavernous sinus that I, explained to her. It would be hard for anyone, I think, to tell her that they can cure that without maybe giving other endocrine deficits. Because she may go for a second operation and then she comes out with maybe low cortisol or something else. And I was trying to see how can I increase the Cabergoline dosage to maybe maximum 3 milligrams per week. So I don't know what kind of experience you have with this, but her small residual is still secreting an amount of PROLACTIN that doesn't allow her to have kids so far.
Professor Laws, what would you do? She doesn't have a endocrinologist right next door.
Right. Well, I don't know how expensive Cabergoline is there, but you could push the dose, I think, for a while and see.
Yeah.
Because one would hope that with more than we would like to give, or maybe give it 3 times a week or every other day, and a little bit more, and maybe it will help the residual tumor congeal and
Yeah.
and hopefully wither away
Yeah.
and die. But I think I would try that before going back to surgery.
Exactly.
Unless
Yeah, that's what I thought. I saw
obvious,
some papers saying that they went up to 3 milligram per week. So since she has been on 2 milligram, I felt like I can push.
That's a lot. Yeah, but we could
Yeah,
push.
and she has been tolerating very
Sometimes
well.
we push it farther and make sure the
Yeah.
assay is okay, and you're not being
Yeah.
fooled by that. But she has not resumed menses.
No, she hasn't.
Yeah,
And
that's
she has no kids
the
for
important
many
thing.
years. Yeah.
Yeah, I mean, in our institution, we've taken it up to 0.5 milligram daily if need be, and generally we would take it there and leave it for 6 months, even up to a year, before we consider it a complete medical failure.
So
Okay.
Edgar, what are the challenges with working as a team in Colombia?
Well, I think that we have a good team, an endocrine team, and we work together. But the main problem is that, unfortunately, we don't have a good healthcare system in general. I mean, not within the hospital, because it's good. It's good enough what we have within the hospital. The main problem is that the health insurance is not covering the surgeries, not covering the education. So that's the main problem. We cannot do the follow-up because they want to put them in a different institution for the follow-up. So we don't have a good, complete treatment and follow-up of these patients.
So it's interesting, these challenges that we don't think of in the United States very often. Claire, do you have to rent a neuronavigation system for your pituitary surgeries?
I don't do pituitary surgery so far.
Oh,
I didn't say so because I don't have access to endoscopic instruments.
Right,
yes.
right. Last time we spoke,
but my hospital is looking forward to have me an endoscopic, a full equipment, maybe hopefully by next year. So all patients I see have been operated outside, or I send them to my colleagues. Well, so the PROLACTINomas, I try to manage myself, because I know how I can initiate the medical treatment and follow them, unless, like for this kind of patient, I have some difficulties. That's where I feel like I need an endocrinologist to follow them. But I think it's a good start when I have endoscopic equipment, and then I will see if I can team up with a newcomer endocrinologist and initiate them to pituitary tumors, hopefully.
Excellent. And any one of the panelists with any closing thoughts?
I just want to thank everybody here for all the recommendations and all the thoughts about this case. It's really useful for my further cases, and I have to follow up this patient for a new MRI and all the endocrine workup. Unfortunately, during the pandemic, patients are pretty scared to go out and do all the follow-ups in the hospital. So I don't have good follow-up right now, and they are from different cities and small towns, and sometimes it's really difficult for them to come to the city, because there are many restrictions of mobilization all over the country.
Yeah, it's this global discussion actually brings up a lot of interesting points. Like we as Professor Laws is saying, that we should think about indications for operating on prolactinomas, and that might be even more so in low to middle income countries where cabergoline is either inconsistent or expensive or not accessible, or endocrinology follow-up is not optimal. That we should think of a broader approach and concept of operating on prolactinomas.
Yeah, I think as these women get more educated and realize that some of the symptoms that they're suffering may be related to the drug and they can get without it. I mean, I never try to sell surgery, but they figure it out, and there's some of them are very clever and say, I don't want to take this medicine the rest of my life. They won't be able to tell me how long it's going to last. I don't like the way I feel. And then you operate on them and they say, I got my own body back, you know,
Right.
and that's a wonderful feeling.
Yeah, I mean, and as I was saying too, you know, well, to reiterate one of Dr. Slaw's slides, that the endocrinologists are your friends, not your enemy. You know, I think that the decision making on this is complicated enough within, you know, the context of the patient's socioeconomic status, plans for fertility, everything else, that, you know, depending on all those specifics, sometimes it's the endocrinologist that's asking you to operate instead of, you know, recommending Cabergoline as a first step. And then there are patients who fail. And then there are patients who know that they want to get pregnant and don't want to be taking the pill anymore. You know, there are a lot of different circumstances where I think surgery for prolactinomas may be the right answer and not the wrong answer. Also, as Dr. Laws was saying, there are these vague things that patients feel. And that's not just true for prolactinomas, it can be true for some microadenomas too. And in fact, we did some research suggesting that there may be a reason for microadenomas to have some visual impact. And I think that, you know, as the endocrinologists get more confident that their surgeons can do this safely, they oftentimes become the most aggressive people recommending surgery.
Yeah, that's true.
So
I have something else if you want, well, that I just thought would be helpful because of the context of this. And that's when predicting what's going to happen to failed vision when we operate for visual loss, for any kind of cyst, tumor, whatever. And I'll tell you what I have come to tell the patients. And when they say, am I going to get better? And how much better? And, you know, they want to know that. And basically we don't know that. And we thought that the ocular computed tomography was going to help us, but it really doesn't. So what I tell them is that we can usually turn the clock back 6 months in terms of their vision. And sometimes it's even better than that. But that's our track record. And that's, you know, I've been in a bunch of lawsuits where they complained about delayed operation, and if it had been done sooner, it would have gotten better sooner and so forth. So calibrating this hasn't been done very well, but just for my own peace of mind and my own experience, I think it's a reasonable approach for the patients that are sent to us with you know, significant visual loss over a period of time. And many times it's years.
Right, right. So with that, I think I'd like to wrap this session up. I'd like to thank all the panelists. Elizabeth, excellent job with being on the hot seat. Hopefully it was not sizzling. Dr. Ordonez, that was an excellent case to bring to us, and it brings up so many points for discussion. So thank you for that, nugget of gold that you brought to our attention. And my old roommate, Ed, it's always good to see you. You're as sharp as ever with all the pituitary cases. You're certainly better than I am on all this. And it's not every day that we have a true master with us on these webinars. And so for Professor Laws, it's an honor to have you with us for this long and for you to share your wisdom with us. And I hope that we can invite you again at some later point for this webinar. Before we sign off, we are back live in 2 weeks. We have a real treat next time with a very, very weird and unusual zebra kind of case. And the panelists will be Andre Chutka and Amir Dadashti from Hofstra Northwell. So with that, I bid everybody who's in Europe and beyond good night. And for everybody in the United States, have a good rest of your day. And again, thank you for all the panelists. And it's been a wonderful time. Thank you so much.